All right, for the sake of time, I think we're going to try to get going on this. So this will be a board review. I put a bunch of questions in. They're going to start off easy and then they're going to get a bit harder as we get going. But I've mixed in quite a few different types of questions on this. I'm going to throw up some polls intermittently um, to get your kind of idea where people are at on this and see how that works. And I'm going to talk through some questions and see how that goes on this, and give me feedback at the end and see if we repeat this format or how we can tweak it to get a better format for everyone involved on that. All right, so this is number 17 here. I'm going to record this one. And again, we have a bunch of programs. We're going to try to continue to expand it out this year. Our goals are going to be to review material for the ARDMS exam. That's the ultrasound exam. On that, we're going to talk a little bit about physics, anatomy, and pathology on that. All right. I just muted stuff because the sound might not work out. So, all right. So we're going to start out with this question. When imaging the adult hip, which is the best probe to use on that? Vote with the poll. I'm going to see how quickly this takes. If it takes too long with the polls, we're going to skip these. All right, so as you put your answers up there, that the correct answer is going to be A on that. So just a little bit tricky question. You'll get a better image um, with a linear probe, but they're really looking to see most people in the US whose hips are big, you're going to use a curved probe with a low frequency on this. So these can be used. Most curved probes don't go up to 10. So this would, people pick C, this would not be a good answer. You know, most curved probes are 1 to 5. So on that is pretty much what they're looking for, the general principle of frequency, lower frequency, deeper penetration on that. Let's look at the next one. The ideal position to evaluate the infraspinatus is shoulder abduction, shoulder flexion, shoulder external rotation, shoulder internal rotation. Just kind of get your ideas up on this. I'm not going to pull this one on that. So infraspinatus is going to be, correct answer will be C, external rotation. Abduction is not good. Flexion is not really helping us. Internal rotation is for subscap, and I'm sorry, I made a mistake in this. Internal rotation is correct answer on this for infraspinatus, and external for subscap. So internal rotation for infraspinatus on that. This is why you examine sometimes when you're sitting, you put the arm across on the opposite shoulder for on that for infraspinatus on that. So this is what they're looking for on this. It makes it a little bit tighter. External rotation is for going to be your subscap. All right, the following are important ultrasound techniques to help diagnose a popliteal thrombosis, except, so remember, except. So I'm going to go through these. Vein compression can be very helpful on that. This is really not a sports question, but they threw it in. It was thrown in the pile of questions. Sonopalpation is not going to be reliable. Color Doppler is reliable because you're looking for no flow or lack of flow, and power Doppler, which would be helpful if you don't see any flow in the vessel. So the correct answer should be sonopalpation on this. To best image the prepatellar bursa, one should consider the following: using an acoustic pad, using a high frequency probe, extending the knee joint, all the above on that. I'm going to try to relaunch the poll. Try to get your answers in. Let's answer quicker. So most of the people are saying D, extending the joint on this. And some people are saying B on this. The answer would be E, all the above on this for this question. Why is that so? Well, one is it's so superficial, so you need an acoustic standoff pad. Two, the higher frequency probes, because it's so superficial, extending the knee joint, any compression of the knee joint tends to push the bursal fluid down and makes it harder to see work extended past the knee joint. So the answer would be all the above on this one. All right, let's go to the next one. Which of the annotations on an image is incorrect? I'm going to just talk through these. Labeling landmarks such as bones, joints, etc. That's correct. Labeling direction, superior, inferior, that's correct. Labeling your impression during the scan, that's going to be incorrect. We never put our impression as much on the image on that goes in the report. And labeling the part of the body being scanned. So incorrect would be C. Okay, what is anisotropy? Let's try to get this on a poll. Hopefully we get this one right. All right, everyone's got that correct then on that. The answer is a comma in the curved part of the supraspinatus tendon. While imaging, where should the focal zone be focused on? The center of the screen at all times? That's not correct. It depends on where our image is. The area of interest being imaged, that should be correct. The area below, no. The area above to avoid artifact, no. So it's the area being interest. You can have multiple focal zones to make this question harder, but the answer would be B here. Please choose the optimal transducer frequency setting for imaging the metatarsal phalangeal joint space. So we're thinking very superficial. The question is really just focusing on principles of frequency. So 6 is too low, 12 is perfect, 4 is too low, and 3 is way too low. So 12 is the answer. What is the normal appearance of articular cartilage in relationship to bone? Bone is hyperechoic, articular cartilage is hypo. That sounds correct. Bone is hypo, that's wrong. Bone is hypo, that's wrong. Bone is hyperechoic, articular cartilage is hyperechoic. No, that's incorrect. Remember though, meniscal cartilage can be mixed echoic on that. So, but articular cartilage is hypoechoic. So the answer would be A. All right. We're going to keep moving through this as we get going. If you have questions or chime in, I'm going to keep throwing in some quizzes now and then. The sound waves in modern ultrasound probes are created by let's try this poll. Answer quickly. All right, we pretty much, everyone's got that one. Answer A is piezoelectric crystals. That's correct on that. Which ultrasound parameter may help in imaging deep structures of the hip on that? I relaunched that poll. All right, that one's a little bit tricky. Increased frequency, no. Superficial focal zones, no. Extended field of view, no. So it's got to be tissue harmonic imaging. It's just a way just to improve the quality of the image, particularly on deeper structures. Basically uses algorithms to reduce scatter as you go deeper and to get a more precise image on that. So the answer would be tissue harmonics. The ring down artifact in the hip replacement is from. Okay, metal prosthetic. Yep, postoperative muscle, joint fusion, sign of failure. No, it's pretty straightforward. All right, this one's a little bit tougher for some people, might not know it, so let's try this one. The ALARA principle relates to it's as low as reasonably achievable. Try that one. Right? It's basically, think of what it means, using minimum exposure time. Yes. Using minimum output of power, using adequate gel. No. So it's A and B. The correct answer would be A and B on that. So that one is really mostly talk about power, on our settings. Most of our machines, we default to 100, but like if you do OB, you don't want it to be at 100. But it's probably okay as long as you're not spending forever on one spot. But you do want to be aware of the principle. It's more important for certain other structures that you're dealing with on that. All right, let's move forward. The best transducer for imaging superficial musculoskeletal structures such as tendons. All right, that one's straightforward. Linear transducer with a high frequency is the principle we're after. The concept of rapidly alternating electrical current to the transducer crystal to convert energy, is going to be piezoelectricity, which is the principle of ultrasound that we use on that. Though with these other, with the butterfly, it's now a chip. So this really probably has to be different. All right, this one might be a little tougher. The following image demonstrates the ultrasound physics concepts of. Let's try this one. So we have some people picking A, some people picking C. Try to get your answers in. So let's just go through this. It's showing these objects are closer and it's only showing it as one. So basically what it's telling you is it can't resolve the separate when they're this close together. So it's going to be resolution, certainly not going to be pain. The depth is really not changing. So this should be resolution on that they're really looking at. Can't resolve it when the two objects are too close together. The computer will put them as one. So resolution. All right, I'm going to get into some clinical ones now on that. And so start these. I'm going to put some polls up. All right, I didn't read this question, but get your answers in if you can. All right, pretty much most people got that right. It's going to be A and C on that. Basically, when you have a cuff tear, you're going to see elevation of the humeral head, and C, this will be in AC sprains. So correct. All right, a 45-year-old comes to the office with right shoulder problems. On that, this is the picture. Really, I don't know how it projects, but focusing on here, we see a hypoechoic area that runs from bursal to articular side on that. Right, so it's pretty straightforward. Everyone's kind of gotten that one on that. It's pole thickness tear. Good. The following image represents a ganglion cyst. No, a foreign body. It could be, but you would expect a lot of different scatter region and calcification. More than likely, it's hyperechoic anisotropy. Absolutely not. You have the patient in a modified cross position during examination of the rotator interval. An increased distance between the bicep and subscap tendon is revealed along with thickening. We kind of talked about this in last week's session. So I think we're all going to get this right. So just choose your quick answer. Yes, capsulitis is absolutely right. So that was good. We're learning things. Not many people missed that one. That's good. All right, in this transverse image of the thigh, what muscle is likely torn? It's the most superficial. Here we see a hypoechoic area, so it's going to be rectus femoris. Rectus femoris. We're going too fast, too slow, or just about right. If you have feedback, use the chat button, or just let me know if I'm going too fast. Just give me a holler. All right, let's move on. They're going to give you a lot of clinical questions. Even if you don't do ultrasound, you can answer a lot of these things on that. I think because there's some sonographers that take it as well, but they've been splitting the exam up now to make it just for physicians, at least for the ARDMS. The following image demonstrates everyone's got that olecranon bursitis on that. In the following image, the anterior inferior iliac spine, what is the most likely diagnosis? So we're seeing calcifications here, which would be consistent with myositis. And anytime you get to AIIS, you're talking about an avulsion injury on that. And there's already calcifications. So it's probably older because there's multiple calcifications on that. So the answer would be a chronic rectus femoris. Again, just going back here on this, you know, they try with your anatomy. Anterior superior iliac spine would be sartorius, while AIIS is the rectus. So just beware about that. It'd be a common question. All right, the following image to the left eye was obtained on a patient presenting with a chronic palpable mass that's been present for 5 years. So clinically, I think we all would think of this as a lipoma, and we see the common features of it. It looks like a lipoma. There's no invasion into the bone. There's no Doppler on it. There's no fluid around it. It doesn't look like a lymph node on it, and looks very similar to the a fatty structure. So this would be a lipoma. Okay, the image below demonstrates a tendon defect near the insertion of the supraspinatus. So what do people think this one is? Be careful of the terminology here. We see a lot. I see a few different answers on this one as you guys vote. So just going through it as you put your votes in. A full thickness tear with retraction? Absolutely not. There's no retraction. It's not full thickness because it doesn't go articular to bursal. So that's absolutely out. No one chose that. Some people chose B, intrasubstance tear. An intrasubstance, well, it's attaching to the articular surface, so it's not technically intrasubstance. Intrasubstance wouldn't touch the articular surface, so it's not an intrasubstance tear. It's not tendinosis because really the pattern is the same on there, and it doesn't look any thickened. So it's confusing when they use this term rim rent, but a rim rent tear is what a lot of people call this. So that would be the answer on this, which is like basically like a flat tire, so to say, but they kind of use that. A defect does not communicate with the bursal surface. So rim rep meaning a tear at the edge or border. I don't really like the question, but sometimes they throw in this kind of stuff, how they write them. All right, this one we should try to pull out. All right. The following image demonstrates what? The money's going on to A. That's right, double contour sign. And remember, look for this as a sign of uric acid deposition in articular cartilage. Very good on that. We covered that in one of the earlier lectures. All right, clinical question. The following lymph node is identified incidentally on a hip exam, and this is big, 5 centimeters. Anything that big is really going to be a problem. So looks like a lymph node. So, but it can't be really normal at 5 centimeters. You don't know. It could be a reactive lymph node. This is possibly malignant, being that big. Certainly needs further evaluation. And I don't know what that one is. So that would be C. Okay. All right. This one's straightforward. The following images are obtained in the antecubital fossa, the ultrasound finding drips, and injury to the, we all see a tendinous structure going in with ecchymosis. So this would be a bicep tendon injury on that. All right, this one might be a little hard for some people, so let's try pulling this out. Right, plantar fascia here, and then you look for a structure sitting in the fascia, more in the mid substance, and it's not a foreign body, it's not a ganglion cyst, it's not a sarcoma, so that would be a plantar fibroma on that. The location on this, and it's a good thing to look for. So just a hypoechoic nodule within the plantar fascia is a fibroma, and that's a plantar fibroma. Good, most of us got that right. Also known as Lederhosen's disease. The image below, there's increased echogenicity of the muscle groups anterior to the femur. A patient with a prior hip replacement. What does this likely represent? Foreign body, no. There's no see-through transmission and scattered, so this is myositis. Gas would be hypoechoic. It's not a normal finding. It's not the prosthesis. So that one we don't need. All right, we're gonna get a vote on this one. Okay. Asymptomatic patient who's had a hip replacement, a lot of just mixed echoic fluid, can look like a tumor. So this would be a pseudotumor. You can't tell infection with ultrasound. You really would have to put a needle in. Though you can get an idea whether it's a higher risk, but you can't tell an infection. So they'll try to trick you, on this. So you can never answer infection unless you get some fluid back, because you can get misled either way. It's not AVN. It's not a tumor per se. It's kind of a fake tumor. So most of us got that right. And let's just spend a minute reading that. Okay. You're examining a patient who may have an A1 pulley rupture, which will be a common ultrasound finding. It's not going to be stenosis because they ruptured. This isn't necessarily going to be, it's either going to be volar or dorsal when they give you this. So it's going to be more to the volar side. Okay, this one's a little tougher. A female college volleyball player reports with a sudden onset of shoulder pain after serving a ball. What is the most applicable finding on the image below? I'm going to let you vote on this one. A lot of money's coming in on D. That looks correct. Good. So medial sublux bicep tendon and bleeding into the joint. Well, we're not really in the joint here. You don't see a halo around the bicep, so it's not that. The bicep is medially subluxed and a subcoracoid bursal effusion. We don't even see the bursa here. Rupture of the bicep and subscap. Well, the bicep's intact here, so it's not that. So it's got to be D, medially subluxed biceps caused by subscapularis. This looks like a defect here. Good, excellent, very good. Okay, sudden onset and goes along with this, etc. All right, some more questions on some physics and probe positioning. When injecting the piriformis muscle, the patient is placed prone. Yes, obviously it can't be supine, so those two are out. A curvilinear probe and placed in a longitudinal orientation or in a transverse on that. So usually it's placed in a transverse or on that, and then move the leg in and about. So C. Okay. Best position to image the ulnar nerve for stability on this. Think this through. Transverse plane is correct. Between the lateral, no, ulnar nerve's not lateral. So it's going to be transverse plane between the medial and the radial process. No. So it would be, answer would be C, where they flex the elbow and look for the nerve to pop out on this. Okay, next question. The best plane to image the iliopsoas tendon. Short or long axis above the hip joint. Short or long axis posterior to the hip joint, no. Short axis lateral to the hip joint, it's not lateral. Long axis medial and posterior, no. So it's got to be short or long axis above the hip joint. What is the best plane to evaluate pathology of the insertion of the distal rectus abdominis muscle in common aponeurosis? All right, we'll try to vote on this one. I didn't look at all these questions, but this one is not worded well, so I would be hesitant to use it. I don't think it's a good question. So if you're looking for the pathology, it's really tough the way they have this worded. I would normally say it's going to be B, but I don't think that's what they're trying to get at. I don't like this question at all. And we have our answers are all over the place. So they say transverse over the pubis between the rectus abdominis and adductor. When you're doing your dynamic exam, that is correct answer. I guess if their pathology is in the tendon, you would do this sagittal oblique. So, but when you're looking for a hernia, that would be the answer on that. So that would be, that's what they're kind of going at. Okay. The rotator cuff is continuous tendon structure made of a variety of tendons. In the interval, the optimal patient position to evaluate this area is on that. We kind of talked a little bit about this yesterday. You do the modified cross to see it in short axis, but the arm is in external rotation in longitudinal plane, it would be better seen. So it's external rotation on this. All right, I'm going to post this one, try to get this one and see what your thoughts are on this. So it's ulnar-sided pain with pain on sinus palpation. So you know you have certain things ulnar side. It's not going to be a Stenner. So then you're really going down. Is this a fracture? No. And we're not over to capitate. So it's got to be flexor carpi ulnaris. Excellent. We all did well on that. Good. Okay, 26-year-old runner has been diagnosed with runner's knee. I don't know if I got the right picture in this one. So the answer would be probably A here for plica on that. This picture's not really as up patella, so I'm not sure I got that in. And plica is really basically pain. It's a remnant of the capsule or bursal tissue. And so you can see that in normal findings. So it's really pain, palpation and pain over the area. Okay, let's do a quick poll on this one. It's not a ganglion cyst, right? It's not this one. Is it a lipoma or a lymph node? It looks like it has a hilum to it with the arrow, so it's got to be a lymph node on this. That's my guess. Yeah, so they have this kind of fatty hilum that kind of goes through the area on many of the lymph nodes on that, and the size of that looks like a lymph node. Lipomas tend to be quite a bit bigger, so when you see something that small, you got to be thinking lymph node, particularly on the location on that. All right, so let's try this one. You examine a patient with leg swelling, ultrasound of the vein. I don't know why they put this one in there because it's not a vascular exam, but you should be somewhat familiar with it. It's not a neurofibroma. They're telling you it's a popliteal vein, so you know it's either going to be an aneurysm. I mean, it could be a Baker's cyst in the area, but this looks nothing like a Baker's cyst. They'll give you the classic stalk, so it's got to be a deep vein thrombosis. There's, kind of poor flow through the vessel. So that's a clot. So deep vein thrombosis. I mean, it's important to be able to have an idea if you look back there and screen, but you're not a full vascular exam. Identify the superficial structure indicated by the arrows in the image below of an area near the forearm. So it's not a blood vessel, not a ganglion, it's not a foreign body. This is a lipoma that you see it kind of mixes in with the fatty structure on that. That's what a lipoma would look like. Oh, we got about 5 more minutes. All right, this is a good one. Let's see if everyone gets this one. Again, the history, you can kind of, even without knowing ultrasound, you should be able to get a lot of these. Right, so this is what a stress fracture would look like. The periosteal reaction on that. So everyone's got that right. Good. All right, so this is pretty straightforward. Patella tendon question. It's not Osgood-Schlatter, it's distal. It's not Hoffa's down here. So with the Doppler, it's more tendonitis. It's around it. Tendon's intact. There's maybe a small interstitial tear here, but the answer would be tendonitis that they're probably looking for. All right, one or two more. I'll let you read this and vote on it. All right, most of the people have gotten this one correct. So this tendon is thicker. There's somewhat loss of echogenic pattern on that, though that can be somewhat at the angle. So it's suggestive of tendinosis. There's no full thickness tear. We don't see any of that. Impingement would do a dynamic test, and stress fracture, there's normal dips, particularly in the cuff, in the infraspinatus. So would be a normal, either vascular channel or normal dip to see. So that would be the answer, would be A, supraspinatus. All right, last question of the morning. The following image reveals a mass in the tarsal tunnel. I'm going to launch this one. This most likely represents A. All right, get your votes in. It's about half and half between A and B. No one's going with C or D. Come on, everyone. All right, about 80% of people, it's 50-50. Somebody break the tie. Somebody's not voting. I'm not voting. All right, I'll leave it at that. So definitely right. It's not a sarcoma. If they're going to give you a sarcoma, they're going to show probably very Doppler and invasion of surrounding tissue. A tophus can look like this, but here we see a picture of, they're telling you it's in the tarsal tunnel. This is the nerve. So this is connected to the nerve directly. So it's definitely not a ganglion cyst on this. It could be, but ganglion cysts tend to be septate, very hypoechoic if they are, and this is a nerve sheath tumor. So this is a schwannoma on that. Anytime you get anything around a nerve and you see connected to a nerve or a mass around a nerve, your answer's got to be schwannoma. So that will be a schwannoma is my guess. Schwannoma. Biggest thing is this peripheral nerve continuity. Okay. All right, I'm going to launch one more poll on this. Bear with me a second. Give me feedback on these. Okay. So, all right. So I'm gonna, last minute, uh, the feedback has been to keep these going. I think we're going to do these quarterly. I'm going to go over different body parts a little bit more clinically as we get through different things, but I threw in some of the physics up front. So we'll try that. And if you have other thoughts on the format here, more polls, less polls, more voice, more just hearing my thoughts on how I think about the questions. Let me know what you think is going to work and do that. The next Journal Club is probably next week, but I'm still not sure. I have some family and personal stuff I have to see, but we'll definitely do one in the next 2 weeks. And I'll let you know on that. And we'll keep moving this forward on that. Thanks again for your time. Have a good weekend. Be safe out there. And hope you're got something out of this and learning today on that. Bye.